So my name is Janice Tsoh from CARE and also University of California, San Francisco. And I will be your host together with Dr. Joshua Grill, who is also here. And we also have a full agenda. So a couple of logistics as a way to welcome all of you. I know we have also both CARE team member and as well as our community partners, and also for those of you who may just heard about CARE Registry, what is that, and all that. So we're going to answer your questions today and letting you know about the updates. So the logistics would be, please introduce yourself through the chat. If you may, your name, your affiliations. If you like, you can even put down like perhaps the AA and HPI groups whom you have worked with, or your projects have been having some focuses on, if you would like to do that. But definitely please include your name and your affiliation. We'd love to hear that. To get things flowing, we're going to, invite you to perhaps include your questions, in the chat box, and we'll do our best to get to them. And we will have our Q&A, but toward the end. Okay, so all right, and we are going to get started perhaps in the interest of time. So we will have a full agenda today. So we will start talking about overview of the CARE Registry, and then Dr. Joshua Grill will tell us more about how to use CARE. We also have Samira sharing with us community perspectives and a partnership with CARE. And then our last presenter will be Dr. Kaipeng Wang, and who will be sharing about the experiences using CARE for study recruitment. And I hope all of you will stay to the end, because we'll not only have more questions and answers and discussions perhaps, but also we will have raffles, and we would like to hear your thoughts and feedback as well through our evaluation survey. Yes, thank you. So please include your name and your affiliation, perhaps your experience, or with any of the AA and HPI groups. If you'd like to include that, we'd love to hear from you. So please make use of the chat. So all right, let's start our plan today, going with the introduction and talk about what is CARE Registry. So again, my name is Janice Tsoh. I'm one of the CARE multiple principal investigator from the University of California, San Francisco School of Medicine, Psychiatry and Behavioral Sciences. All right, just a little bit of a background about Asian Americans, Native Hawaiians, and Pacific Islanders. Many of you know AA and HPI are the fastest growing racial group in the United States for the last couple of decades. We have, more than actually 26, 27 million of AA and HPI in the United States, constituting nearly 8% of the total population. If you think about the diversity, the heterogeneity, more than like 30 Asian American groups, 21 Native Hawaiian Pacific Islander groups, together we have like more than 100 plus languages and dialects, thinking about immigration backgrounds, religions, and all of other factors relevant when it comes to health and many important aspects. It's definitely a very diverse group that we are all in, that we're working with. The graph with the red bars showing on the right really just examples of, in terms of the diversity and also the importance of languages, thinking of like really there's a variety when it comes to percentages of populations with limited English proficiency among our AA and HPI groups. Now, keeping these numbers in mind, next slide, please. And if we're talking about research funding, from the NIH, from the National Institutes of Health, less than 1% of the total budgets were dedicated to projects that have a focus on AA and HPI participants. Now, if we're talking about, as an example, of more than 50,000 participants who were enrolled in ADRD, Alzheimer's disease and related dementia studies at the Alzheimer's Disease Research Centers funded by the National Institute on Aging, only 2.8% were AA and HPI participants. Now, giving these in mind, certainly many of you would agree, effectively engaging AA and HPI community to participate in research is quite an endeavor. Not impossible, but a lot of things such as cultural, linguistic, differences, and also awareness and the need of outreach, building trust with the community, and then really sharing with the community, increasing the awareness and the understanding of the value of research in our communities. All of these are important. Not only that, talking about the other angle of it are our communities, our research partners, our research communities. They are really also needing to increase the education and awareness as well. Now, next slide, please. All these underlying the core mission of CARE, which is to pave the way for meaningful inclusion of AA and HPI participations, to increase the representations of AA and HPI participants in research. CARE is funded by the National Institute on Aging by 2 grants, a R24 and currently a 5-year R01. We have 3 principal investigators, Dr. Vantar Park, who founded CARE and also the Contact MPI, myself, and also Dr. Joshua Grill from University of California, Irvine, who also will be speaking with us shortly about more about how to use CARE. What are the goals of CARE? Number 1, to address and reduce the disparities in research participation in Alzheimer's disease and related dementias, aging, caregiving, and other health issues across the lifespan among AA and HPI populations. Importantly, we wanted to give our AA and HPI community members a voice and the opportunity to participate in research through enrollment in CARE. Last but not least, our goal of CARE is also to implement effective, culturally appropriate, and innovative recruitment strategies in collaboration with our CARE's community partners to enroll our AA and HPI community members who are interested in participating in health research. Next slide, please. Here are our wonderful partners. Many of them are also in the audience as well, and many of the logos you could see that are familiar to you. Our partners, not only within California, but also nationwide. We're so grateful to have this partnership through CARE, really using the collaborative approach to advance health research and representation among AA and HPI through research and education. We have nearly, or I might say, more than 60 partners now. All right, next slide, please. Who can enroll in the CARE registry? Very simple. Self-identify as AA and HPI adults 18 years old and older who can speak one of the 8 languages to complete the enrollment survey. And certainly the list of language will continue to grow, and who express willingness to be contacted to consider in participating in health research. The languages include English, Chinese, Hindi, Japanese, Korean, Tagalog, Vietnamese, or Samoan currently. And we, as I mentioned earlier, that we're in the process of expanding, including languages such as Ilocano. Participants can also have the option to receive $10 as a small token of appreciation for completing a brief enrollment survey, roughly about 10 minutes, not only offering through online, and you can see the QR code on top of the slide, but also they can do it by telephone or in person with, in collaboration with our partners as well. What is the registry enrollment survey cover? These domains are listed here: social demographic information, health conditions, health behaviors, some caregiving experiences, also willingness and attitudes towards research participation. And all these will be very helpful as we are matching participants to studies and identifying like a potential pool of participants. Next slide, please. Now, where are we currently with Care Registry? So since its inception, the launch in October 2020, we just celebrated our 4th anniversary, by the way. And as of last week, we have more than 12,000 enrollees in our Care Registry. And many of those, you could see that they're born outside of US. We started off as a California registry. So we have 80% Californians, and we are looking forward, as the next meeting, we're going to report that this number will be decreasing because we'll have more enrollees who will be joining us through the Care Registry, so that we are a nationwide registry. Also, 11% has caregivers, current caregivers, and what we are very proud of is that we have nearly 80%, 78.5%, told us that they had no prior research participation. And I think that is so important, particularly in terms of advancing the mission of care to increase AA and HPI representation in health research. And in terms of age representation, 18 through 101, mean age is at about 55, and we have 1/3 of those at age over 65. We have 2/3 of female, so we definitely want more male participants as well. And then nearly half speak limited English, and we have about 12.5% who reported some ADRD symptoms like confusions, like memory loss, and so on. Now, if you look at the languages distribution, that you can see we have a wide distribution when it comes to not only we have half of the participants filling out by English, but also another half, in fact, more than half, 52% of them completed the survey in a variety of languages, in Vietnamese, Korean, Chinese, and Samoan, and so on. When it comes to cultural group, we have a sizable number. The majority of them currently in the Care Registry include Vietnamese, ethnic Chinese, Korean, and we are working very hard, and we are seeing lots of growth in our Asian, Indian communities, members, Filipino, Samoan, Japanese, Native Hawaiian, other Pacific Islanders, and so on. Next slide, please. How care works. All right, how does this, matching happen? As participants enrolled in care, information saved in the Care Secure database. And for researcher, okay, and they submit a request, getting approval, from their institutional review boards at IRB to use care as one of their recruitment source. Then a matching happens, matching participants and researchers. So care connect researchers with participants who might be eligible based on their criteria and also based on our enrollment information. And then participants get contacted, and participants can then decide whether or not they wish to participate. And there are no cost to participants and researchers. Okay, next slide, please. Now, this information are all in, we are all in the in the website that you can go to. So I'm not going to go into details here, but essentially the process started with filling out a care referral request form online, and you can see the QR code there where you can go directly to the REDCap survey, which has asked some questions, very easy to fill out, and we have a screenshot of that in a little bit as well. And then also it will go through our care consultation committee review, and uh, often, not all the time, a consultation will also be provided and perhaps some clarifications of the needs and so on. And then if everything get approved, including IRB approval, then the next step would be providing a list of participant contact information, their preferred contact information there to the researcher. And currently we're doing in a batch of 50, depending on the scenarios. And certainly investigators have responsibilities to contact, and also we wanted to hear back about the outcomes. And in this process, we are carefully monitoring and tracking, because we also wanted to advance our understanding in terms of the process of referral and engagement and participation as well. And I'm watching some of the questions that there, and then we will continue to respond to them. So please continue to keep them coming. And then, okay, let's go to the next slide. This slide shows just the current referral request form, a lot of check boxes and all that. So relatively easy to fill out, mostly the core information about the study and about the also the purpose of the study and the language requirement, cultural groups, and etc. That would be needed, and certainly the eligibility criteria. Okay, next slide, please. In the interest of time, so this is our last slide because we go to the next presenter. Where are we now when it comes to care supported study? As of this past week, we have a total of 147 studies requested support from the Care Registry. And since 2021, we have made more than 16,000 referrals, and that is about more than 7,600 care participants have been referred to at least one care supported studies. And many of these studies also have study materials and personnel to support the language in addition to English. And also some of these requests are for letter of support for the grant application, many of which also went to NIH applications. For the list of care supported studies, please refer to our website. You can go to careregistry.ucsf.edu, and then you can look into researcher and look into actually is that the resources there, and there will be a care supported studies webpage. And you can see here a lot of the research areas focusing on ADRD and caregivings, but we also have a broad range of health study as well. Many of them say ask all AA and HPI groups, but also we have another half of studies have specific ask for AA and HPI group. So without further ado, I would like to introduce our next speakers, and Dr. Joshua Grew from University of California, Irvine will be telling us more about how to use care. So Josh, please take it away.
Great. Thank you, Janice, and excellent job in getting us started and covering quite a bit of material about background on care and its operations. I'm going to try to be relatively brief in my remarks to save time for our remaining speakers. We can go to the next slide. I'm just going to really try to do 3 highlighted things to help our audience, which I'm really thrilled to see coming from all over the United States and across time zones. That's really central to our goals for care moving forward. Just to kind of put in your minds the possible ways you might consider using care. There's many ways you could use care, and I'll just highlight a few. We can go to the next slide. I'll do them in turn. So first, Janice really highlighted using the ADRCs, in which I'm a part, the low representation across our AA and HPI populations. And in other studies, it's actually even more extreme. So on the left is a study that looked at industry and NIH-funded Alzheimer's disease clinical trials and showed that Asians really made up less than 1% of participants in interventional studies for Alzheimer's disease. On the right is a more recent, larger review of similar types of studies. You can see that the representation of Asians goes up, but in fact, this review included studies that were conducted in Asia, where 100% of participants in those trials were Asian American. So we recognize that care could be incredibly valuable to investigator studies who aren't necessarily focused on Asian Americans as a population, but want to improve the diversity, the inclusivity, and the representative nature of their study by recruiting from care. Next slide. That is probably optimal when you have elements of your design that include randomization. So another example would be studies like clinical trials, but also studies where you simply want to increase diversity in your study, and you have um, uh, methods to avoid any bias that might come from recruiting from a registry. And so I'll come back to this later, but this is something we do encourage people to think about. If you were recruiting from diverse communities and you recruited Native Hawaiians, for example, from CARE, but you recruited a different cultural group from a very different approach, you'd want to, make sure you're thinking about that as a potential caveat to your study. Next slide. We definitely do imagine that investigators will be interested to look at comparing specific groups. Again, a best case scenario might be to recruit all the groups you wish to compare from CARE, so that the biases that come with those groups are similar, although we certainly don't guarantee that they'll be identical. And this would be really potentially powerful, or that you're recruiting these groups from a variety of methods, and you'll increase the recruitment of each of the groups from CARE as well as other methods. Next slide. Again, alluding to these potential for biases, if you wish to compare Asian American, Native Hawaiian, or Pacific Islander groups to other cultural groups, then you'd really want to think about other registries that might emphasize these populations specifically and ensure that you're trying to recruit from similar mechanisms. And generally, we recruit from broad approaches, broad sources of participants, and achieve some level of balance and understanding the potential caveats that could come from recruiting registries. Janice did a really nice job of highlighting one of the things that we're really proud of in CARE, which is that the overwhelming majority of participants in CARE indicate that they've never participated in research previously. So if you're comparing to a group that has participated in research previously, then you'd want to leave open the possibility that this experience in research could drive any observed differences you see between groups, and try to account for that in as rigorous a way as possible. Next slide. Now, of course, we have the opportunity to just answer questions using the CARE registry or even within the CARE registry. And again, Janice highlighted for you the data that we collect in the registry and that we've already begun to use to explore novel research questions. And you too might think about ways to do that inside of the CARE registry by either requesting data from CARE or requesting the opportunity to disseminate surveys to participants within CARE. This could be valuable on a number of levels. You could do it in a small number of people to try to collect essential preliminary data for a grant application that you're working on. And we already saw in the chat someone ask about the possibility of using CARE in a grant application, and CARE has consistently provided letters of support to investigators who wanted to pursue grant funding that's inclusive of these communities. You could do it to try to understand attitudes among specific cultural groups or racial or ethnic groups. Again, with the idea of assessing the need of your community or of various communities, or you could imagine doing whole studies just by interrogating the attitudes of the more than 10,000 people who've already enrolled in CARE. It's an incredibly powerful resource. Next slide. Just, again, just to get your creative juices flowing, we offer what some of these studies might look like. Does the generational status of AA and IHPI communities impact their willingness to do things like participate in interventional research? You could design that survey, send it out to specifically carved out population within CARE, and then create these groups for comparison on the back end, comparing survey results based off of generational status. Next slide. So I've alluded to this throughout, but I'll just close by saying we do work closely with investigators, or happy to help you think about some of the caveats of using a registry like this. You definitely do want to recall that this is not a community-based cohort or an epidemiologic cohort. We can't do things like assess disease incidence or prevalence in CARE. This is a convenience-based but highly diverse and incredibly unique population that can be recruited into other studies, but it is a convenient sample. You definitely want to think about the design of your study and introducing rigor to control for any biases that could come from recruiting a population through a registry. But we do think that this is a tremendous opportunity to increase diversity in your research and increase representation of these communities in your science. With that, I think I'm going to leave as much time as possible for Q&A, and more importantly, our next speaker, that is a member of our Community Advisory Board, Samira Khan.
Hi, everyone. Thank you, Josh, for the intro. My name is Samira Khan. I'm the current president of the South Asian Public Health Association, and we are also a CARE Community Advisory Board member. Next slide. So the South Asian Public Health Association is a national volunteer-run nonprofit. We are the leading voice on public health issues impacting South Asians in the U.S. And since our inception in 1999, we have dedicated ourselves to promoting health equity and well-being of our broader and diverse South Asian communities through advocacy, collaboration, and communication. We aim to address the unique challenges that are facing South Asians and advance opportunities for people to reach their utmost potential health. So in short, our goal really is to connect people, ideas, and resources to advance the health of South Asians in the U.S. Next slide. And of course, this work cannot be done without the amazing board that we have, which again, our entire organization is volunteer run. And so our board is a tactical board. We do a lot of the work that we have produced over the past few years. We also have committee members that help along with it as well. Next slide. So just a little bit about SAFA and our impact areas. A lot of the work that we do falls underneath the buckets of research, advocacy, or education. We also collaborate with other community-based organizations across the country and try to engage with the community and be that bridge between CBOs and researchers and CBOs and advocacy groups. And we also focus on developing the South Asian public health workforce through professional development. A lot of our health priorities are focused around mental health, chronic diseases, and lifespan health. And recently, we've also added on emerging health challenges, women's health, and violence and discrimination. But one of the reasons why we had decided to partner with CARE was because it did fall into the bucket of lifespan health, which is one of our major health priorities. Next slide. So why did we decide to partner with CARE? Personally, I have aging South Asian parents, and I understand the reality of how difficult that can be, both for them in terms of finding, treatments that help, and as well as a caregiver. And so I was very invested in partnering with CARE, and our board had also agreed, given that, it's important that we have representation in aging research for South Asians, given that South Asians are one of the fastest growing ethnic groups in the US amongst the Asian Americans. And a lot of our population is also aging. However, a lot of this data is invisible in national data sets, and there is this need to just disaggregate that data. And so our goal is that by having more South Asians enroll in care, we will have an ample, sample group to take a look at that and really contribute towards disaggregating some of that data. And as I had mentioned, this care really aligns with a lot of our goals to address chronic diseases, aging, and mental health. And it also allows us to really empower the community. We have done multiple events, which I'll talk about in a little bit, with the community, and it gives them an opportunity to feel seen in the data, to be understood, and have their reality reflected in some of the research that's being done. And then long term, it also helps lay the foundation for advocacy and policy change and resource allocation. And so our goal is that the more South Asians enroll in care, the more data we will have to be able to fight for their needs. And then also on a personal level, I have taken that survey so that I can encourage other people to take that survey. And it's been a quick and easy process. And through that, I've been connected to other research studies. And so it's, really, we're not just asking the community to do it, but we are also taking part in this study. Next slide. So one of the biggest benefits of partnering with CARE, both as a community board member as well as a recruitment site, we work in conjunction with Dr. Arnab Mukherjee at Cal State East Bay, who is the site PI there, to reach out to community-based organizations to set up these events. And so he's been doing work across the country, and we've been helping connect with some of the CBOs that we have partnered with, like India Home and Ashiana. And so India Home is specifically in New York, where I am from. And we were, they are essentially running a senior daycare center. They have dementia daycare programs. And so we've been able to do 2 outreach events with them. We've gone there, we've handed out the surveys, we've explained the importance of research to them, and people get very excited, about understanding that they are contributing to research. And it's, a population that is not really reached in research studies. Not like people usually do online recruitment. It's a younger generation that's they're targeting. And so people don't do a lot of that on the ground recruitment anymore, especially given the pandemic. And so it's a nice change for us to be able to really connect with them on a personal basis. We've also done events at other, health and wellness groups. So there was an eco wellness event that we had done where there was like, I think 50 to 60 South Asians who were doing exercises, and then they were enrolled in the study. And so we have been helping with making those connections. We also have an upcoming event with Ashiana, which is focused specifically on domestic violence in the DC area, but they also have expanded the scope of their work. And so they have a senior meet and greet that we are tagging on to help recruit more people for care. And so some of that outreach and education, we've also been doing online. We are planning to host a webinar in September to reach a broader audience about the importance of care and the importance of participating in this research. We've also helped with translating materials and hosting info sessions and promoting this in the South Asian communities. And then we have, worked alongside the site PIs to really build that trust within the community so that more people are open to participating in research. And a lot of this is, we had set the foundation for, but we were able to really put it in motion through this partnership with CARE. And so I really encourage a lot of, groups who are thinking of partnering with CARE to reach out and to do so. And also on the researchers end, because we have been working so hard to have that diversity represented in CARE, hopefully you'll be able to utilize the registry and find participants to enroll in your own studies as well. So thank you for inviting me to speak. That's all I have.
Thank you so much, Samira. And we are really grateful for the partnership. And again, want to acknowledge not only our partners, but also our community advisory board members here. Really, without all of the partnerships and your support, CARE would not be possible. So thank you so much again, Samira, for sharing your perspective. And then we'd like to go to the next presenter, and we Dr. Kaipeng Wang, Associate Professor from University of Denver. He's going to share with us his experience of using CARE to support study participant recruitment. So Dr. Wang.
Thank you so much, Dr. Tsoh, for your sweet introduction. And it's really my honor to be invited here and talk about my projects as well as my experience regarding how Care Registry has supported with my recruitment procedures. But before my talk, I'd like to make two acknowledgements, which I didn't put in my slides. First of all, the original the project focused on three subgroup of population of Filipinos, Vietnamese, and Indonesians. But because when I started using resources from Care Registry back, like I guess 2 or 3 years ago, Care Registry hasn't involved any Indonesian Americans, so I would just focus on my information here regarding Filipinos and Vietnamese Americans. So just to tailor my original product, particularly in relevance to Care Registry. The second acknowledgement that I want to make is overall my PowerPoint structure was trying to kind of mimic or like emanate the presentation structure from Dr. Christina Miyawaki, who also happens to be here today. So I want to kind of acknowledge that, not for plagiarism or anything. All right, so I'll move forward with my next slide. So my project focused on advanced care planning among Filipino Americans and Vietnamese Americans age 55 plus. For those of you who don't know, advanced care planning refers to planning for treatment preferences when people become unable to speak for themselves. Usually, the ACP involves two critical steps. The first step is to have a formal or informal discussion about end-of-life care preferences with family members and or other health professionals or stakeholders. The second step is to really document those preferences for preferences through legal formats, particularly through advanced directives. Research has suggested that advanced care planning, if implemented successfully, has been associated with better quality of care, less unnecessary medical treatment and costs, lower anxiety and distress among patients and their surviving family members. Next slide. However, despite those benefits, research has also suggested a large racial and ethnic disparity of advanced care planning. So taking advanced directive completion for people age 50 plus, as an example, research has shown that people of color are significantly less likely to complete advanced directives than a non-Hispanic white population. And that percentage has happened to be even particularly lower for non-Hispanic Asian Americans. Next slide. There has been, fortunately, there has been some research projects that increasing amount of research that focus on ACP for Asian Americans. By the time of the start of the project, most of the studies have focused on Chinese Americans and Korean Americans only. Obviously, there was a lack of knowledge in ACP among other Asian Americans, particularly related to among Southeast Asian Americans. So as to address the research gap, sorry, next slide, please. The ultimate purpose of this project is to examine the biopsychosocial factors of ACP-related outcomes among Filipino and Vietnamese Americans age 55 plus or older. The specific aims of the study include to examine the association between family relationships and experience of ACP and advanced directive completion, and also to examine how resilience plays a role in advanced care planning. Next slide. So overall, our project used a convergent parallel mix method. So we collected both quantitative and qualitative data. The qualitative data has been, we have already submitted a manuscript for the qualitative data, and we're currently doing the second review. Hopefully it's going to be accepted and published soon. We're going to, we have conducted some qualitative preliminary study, preliminary analysis for the quantitative data, and the results should come very come out very soon as well. To be eligible for this study, participants need to be self-identified as Vietnamese and Filipino or Filipina ethnicity. They must be at least 55 years old and currently living in the United States. We use our original plan of sampling was convenience sampling and snowball sampling. So for data collection, we have collected both quantitative and qualitative data. For quantitative surveys, we use both online survey and in-person paper survey. And for focus groups, we have conducted 3 focus groups, one for Filipino group, which was in English, one for Vietnamese, which was in English, and the other one was for Vietnamese Americans, which was in the Vietnamese language. And all participants, all recruitment and survey materials were translated into Vietnamese and Tagalog. And of course, we included English a questionnaire as well. And participants each received a $25 gift card for completing the survey and a $30 gift card for completing the focus group interview. Next slide. So I want to start with talking about the recruitment process before I even heard about Care Registry. So it started back in February 2022. So I contacted about 7 community organizations that predominantly serve Asian and Pacific Americans in the 6 states. That includes Colorado and Michigan, where we spend most of the time doing in-person data collection. So that includes a lot of temples, a lot of spiritual activities, festival, community events. And for all the other organizations, we distributed survey. I'm sorry about the construction. We distributed our survey through flyers. And then in addition to that, we asked participants to refer their connections, particularly those who are interested and are eligible to the study. So through snowball sampling, as a result, we had 168 participants who complete the survey, including 70 Vietnamese Americans and 98 Filipino Americans. So why did I decide to use Care Registry? First of all, our planned sample size was between 300 and 500. Obviously, we needed at least 132 participants to complete the study. But more importantly, we found that for our in-person or for the participants that I have recruited, obviously there was a lack of representation for Vietnamese Americans, as you could see from the previous slide. And also, more importantly, there was a lack of representation for those who speak English and those who were born or immigrated to the United States at younger ages. This is partially because most people who participate in the events do not speak English, so obviously there was some kind of lack of representation. So just early after I collected about 50 responses, I recognized, there's no way for us to, based on the current enrollment rate, there was no way for us to complete the project. So starting in May, I contacted 2022, I contacted Care Registry, and thanks to Marion and other wonderful colleagues who gradually shared me a total of 1,833 participants who we contacted altogether, and a total of 163 participants completed the survey. That constitutes almost half the Filipino and Vietnamese sample, which yields to a total sample size of 331 for these 2 groups. The primary methods of contact was through email, so each participants were emailed up to 3 times, and the email includes a link to the questionnaire, including the consent form, which is attached in the invitation email. Yeah, next slide. So now I want to talk about my experience about using Care Registry. First of all, I think it's a very easy process. It's a one-time registration through form. The form is very easy to complete. All the questions on the form are easy, and they should be covered in your original proposal. So for most of the kind of short essay questions are I pretty much just copy and pasted the information from my original proposal, which worked very well. And more importantly, I really appreciate the helpful recommendation from the key personnel in the care registry. So for example, I received suggestions in terms of refining the language in the recruitment process to allow participants to understand the context of my study. And also, I appreciate the short turnaround for care registry. It usually takes within a week for me to receive the contact list for the participants. And also, just in case the key personnel happen to deal with some emergent kind of situation or some technical difficulty, they would quickly respond to me and let me know. So you never have to worry about, okay, I don't have anyone to talk to. That had never happened to me throughout the process, and the names and the emails were well formatted for group sending purpose, which provides a lot of convenience. Also, I particularly appreciate that they collected the preferred language in the contact list, so that I know what language to use when I reach out to the participants. And also, at the beginning of the study stage, I really want to start prioritizing people from certain states to ensure the diversity of my participants, and that kind of requests were accommodated very well at the beginning of the study, and I really appreciate the support from Mary and other folks. So this could be this kind of communication could be ongoing, and you could also always like tailor as long as your IRB approves that, you could also always tailor the priority of your enrollment. Also, it is important to know that just as other folks have mentioned, I really appreciate the diversity of participant characteristics in terms of many factors such as birthplace, language preference, etc. And also, recruitment at care registry is ongoing and always updated in a timely manner. So maybe this month you didn't have enough, have a lot of participants this month, but keep in mind that care registry has been actively recruiting participants always. So next month, it's possible that you could receive a list of a few more eligible participants, which happen to me quite frequently. So I really appreciate that kind of update as well. Next slide. I do want to share a couple of lessons that I have learned throughout my process. First, a lot of participants, we have some participants who was kind of postponing the responses to the surveys because of reasons that I didn't know. So I found it very helpful to include in my third email a final gentle reminder or something like that in the email heading, just to remind that this is our last email outreach, so that participants actually feel that the time sensitiveness of the responses, so they could respond to my email. So I always kind of receive more responses when I send out the first email for each batch. Also, I found it helpful to for my study, I didn't have a lot of budget. It was a pilot grant. I probably only have like a little bit over $30,000, and we didn't have enough money to pay for a staff who could keep in touch with the participants. I recommend that if you're applying for kind of larger grants, make sure you budget for some staff members who could follow up with the participants beyond emails. It could be phone or Zoom calls, especially in the language you're not familiar with, or even better, for some staff members who could share similar kind of lived experience with the participants, is going to be very helpful for you to keep track of the participants and establish trust and rapport with the participants, which could tremendously improve the response rate of your survey. Last but not least, I want to acknowledge the contribution and support from several resources, Care Registry, of course. Also, I would like to appreciate Dr. Latson Hinton, who happens to be on the board as well. He referred me to the Care Registry, which really saved my life to some extent, and also really appreciate a shout out to Dr. Marion Zong, who is incredibly humble but incredibly hardworking in supporting my project. I also want to thank my research assistant Carson DeFries and Tsoh, particularly Tsoh, who happens to communicate. Who spent a lot of time communicating with some of the Vietnamese-speaking participants in my project. I also want to thank my community partners, agencies, to support my recruitment, and also Rutgers RICMAR project funding to fund fully for my projects. And that's all for my presentation.
Wonderful. Thank you so much, Dr. Wang. We're so glad that CARE can, join you to advance the representation of Asian American and Native Hawaiian Pacific Islanders in your important study and other research as well. So we like to also acknowledge, thank you, Marian, for showing this slide, a village, multiple villages, of our team members. And I think Dr. Wang mentioned about Dr. Lesson Hinton, and certainly Dr. Marian Zhuang. Marian would be your first contact, in fact, usually when it comes to requesting for a care registry or care supported study request. And also Aiden, a number of our amazing community advisory board members whose names are listed here. Some of them are also here in the audience. And not to mention earlier about various community partners that you saw their logo up there. Now, last but not least, we want to open up the floor for some additional questions and discussions. And thank you all for your participation. I saw a lot of comments and also responses as well. And also we have raffles. How about, shall we actually start a raffle